Good afternoon, ladies and gentlemen. Um, Dr. Alex Thomas, immediate past president of CAHO and the organizing chairman of this conference. Dr. Vijay Agarwal, president CAHO, and the advisor to the Max Group of Hospitals. Dr. C.M. Bhagat, secretary general of CAHO, and the MD of Bhagat Chandra Group of Hospitals. Dr. Jajinder Patankar, organizing secretary of CAHOCON and the CEO of Nanavati. Distinguished faculty, distinguished guests, my seniors, ladies and gentlemen. Let me begin by saying that it's a singular honor for me to be here this afternoon to attend this very important annual conference of the Conference of the Consortium of Accredited Healthcare Organizations. Let me begin by saying that I gratefully acknowledge the organizing committee to get me here this afternoon, and especially the role of Air Marshal Pawan Kapoor. The fact that I'm here is the outcome of his persuasive skills. So that said, let me go on to say that I was trying to understand the theme of this conference. And I dare say that I found it extremely contemporary and challenging. Contemporary because it's really quality of healthcare is all that what we are all striving for. All of us, in different ways and different access, we're all actually looking at the same thing of healthcare. And challenging because we really do not have those indicators, those markers, which will tell you, yes, you got it right. And I think there's a little bit of a disconnect, and therefore the challenge. So the big question, which for us as healthcare managers, as healthcare professionals, is often asked is, does quality of healthcare affect outcomes? I'm afraid the answer is not simplicity. It's not as simple as it looks like, that it's directly or there is a linear relationship. It doesn't work so simply and easily. It's something like, in the medical records, the nurse's medical record as to the diets was concerned, he said the patient had an exuberant breakfast. He had waffles and chocolates and dosa for breakfast, but was anorexic for lunch. So, anorexic outcomes. So, the fact of the matter is, there is a disconnect in the understanding of what we are talking about in quality of care versus what we are looking at in outcomes. So, let me begin by saying that over last about 5 decades, global healthcare systems have been trying to analyze and assess what should be the yardsticks of quality of healthcare. I don't think the definitions are clearly defined, and the real answers still continue to be a little elusive. But because if you look at it from the perspective of a doctor, what is the doctor looking at? If I'm a clinician working in my hospital in a system, what do I want? I want a good infrastructure. I want a good clinic. I want a good ambience. I want medicines to be available. I want a good staff. I want early turnover. And my funding should be right. So that's my perspective as a doctor. A good infrastructure. The patient, we heard so much about patient factors. Patient wants quickly to be cured. He wants early relief. He wants a courteous staff. He wants good ambience. He wants good nutrition and food and things to that effect. So quality is changing from the patient's perspective. And look at it from the stakeholder's perspective. What does he want? He wants limited loss of man days. He wants decreased disability. He doesn't want too much of disability to be going away. He wants increased availability in outreach setup. So he wants to reach out to the population at large. And therefore, the stakeholder's stake is so different. What about the financer? What is the person who's wanting to give you the funds? His stake is absolutely different. What he's looking at is the cost to benefit ratio. He's looking at the cost to cure, whether there are any malpractices, etc., etc., etc. So his stake as a financer or the fundraiser is different. And the government, what is the government looking at? The government is looking at is there effective utilization at a low cost? The economics, the economic model, the template, outcome parameters like patient satisfaction, cost of care, cure rates, disability, maternal infant mortality rates, revenue earned per bed, patient satisfaction indices. Now, these are some of the issues which the government is looking. So now come back. Quality of healthcare. Each person having different indices. So it is a huge canvas. And how do we try and connect all the dots and look at outcomes? That is really the big question. So if you look at it on a very larger canvas, when we talk of quality of healthcare, we are actually looking at the infrastructure that you provide in a healthcare process, plus, of course, the process, the work, the process of provision of healthcare, which together, that is a structure plus the process, if you translate that into action, you would actually be looking for a linear relationship for good outcomes. But that's the challenge. That's the challenge where it comes, where you cannot measure many of these imponderables and intangibles, which cannot actually be measured, and which one has more importance in which scenario is really the big question. I'll give you a small example. If you look at the use of beta blockers in ST elevated myocardial infarction, we all know that it's evidence-based medicine, that if you give beta blockers in ST elevated myocardial infarction, the salvage rate is better. Now these are meta-analysis, Cochrane analysis have been done, and we know that it's standard of care. Now, let's look at outcomes. If you give beta blockers in an acute MI, does it always happen that the outcome is going to be good? No, because there are so many other factors. There may be comorbidities, there may be other problems, there may be other issues, there may be genetic factors and environmental factors. There are far too many factors to talk about, and therefore, not necessarily. So therefore, whereas it is the standard of care, it is the process is right, but outcomes cannot actually be correlated. Let me talk about two very high-profile failures which happened in the past in the UK. They are important because they give a message. I'm talking of the National Health Service of United Kingdom, and this is what they said. There was this Bristol, in Bristol, there was this infirmary where they were doing open heart surgery for children, and they found that there was large amount of mortality. So they did a root cause analysis and this inquiry, and they went ahead and did this inquiry, and they found that they took in about 557 witnesses, 238 parents, 1,800 records, and they found it was an absolute disaster. The pediatric cardiac surgery, the indications for surgery were inappropriate. The mortality, when they did a run chart, they found was actually double of what was expected in 7 years. There were 34 excessive deaths in less than 1 year. The causes of mortality could not be explained by the case mix and the high risk. The care of the patients was actually being done in two locations, in the ICU plus in the wards, and therefore there was a total confusion. There was no pediatric ICU, it was an adult ICU. There was shortage of nurses. Um, um, there was a very disorganized system in communication. There were conflicting decisions. There was no one really in charge. And failure in informed consent was yet another problem. And there was this old boys culture that they talked about, wherein they would want to protect the doctor's interest and not sweep it under the carpet. So lack of monitoring. So all in all, it was courting disaster. So this was the consensus. So when you look at a process, here is a story where the whole process failed and it resulted in a disaster, and the outcomes is for all to see. And therefore, many things had to be set right before they could set things right in Bristol. There's another story about the Shipman murders. There was this gentleman called as Harold Shipman in the UK. He was a general practitioner and he was working in this NHS hospitals. And he, as a part of euthanasia, would give sedatives and opiates to patients, sometimes in such large doses that he killed people to more than nearly 500. More than 500 people he killed by excessive dose of opiates and other sedatives. He's still in jail in the UK. It is a process. You have allowed somebody to go ahead and do into a process, and that has translated into an outcome. Look at this, a 2-year-old child who has an intra-abdominal tumor, treated, tumor out, chemotherapy given, last dose of chemotherapy being given, and somehow in the pharmacy, the pharmacy technician gives 20 times more of NaCl in the TPN bag. 20 times more. The baby dies in a couple of hours. The baby dies. It's a sentinel event. It is a process failure. And the outcome is directly proportional. There is no doubt in that. The point which I'm trying to make, ladies and gentlemen, is that there are these issues of processes in your system, in your organization, in your quality management, which would require for you to ensure in terms of looking after. And without that, I'm afraid there will be problems. Let me also talk about one or two more things about surrogate markers and intermediate endpoints. As you know that in diabetes, HbA1c measurement is extremely important. We know that about 6.5 to 7 is what we would want to ensure. But are you also monitoring the amount of hypoglycemic spells? Now, so therefore, it becomes a surrogate marker. Similarly, if for a hypertensive, if you are wanting to achieve a blood pressure of 140 by 90, you have achieved 140 by 90, but are you monitoring the amount of orthostatic hypotension he's also having? Now, those are intermediate endpoints which we are not monitoring. I think there's a need for, when you look at outcomes, it's important for you to ensure that surrogate markers and intermediate endpoints are also kept in mind. I'm going to talk a little bit about the armed forces, which have been the pioneers in quality healthcare over the years, ladies and gentlemen. As you're aware that in the armed forces, we draw our functions drawn from the hierarchy of various army orders and rules and policies and DG memorandas and treatment guidelines, protocols and SOPs. There are a series of repetitive tasks. They are drills which are tried, tested, and have improved over the years. The feedbacks are well developed. There is channel of communication, and performance is an integral part of our system. Peer review is always is ongoing, and there's training of doctors, nurses, and our paramedics, which is done every year in our training calendar. We have 135 hospitals. We have 100 mobile hospitals. We have 250 small healthcare facilities. And the task for us in the armed forces is all cut out for us. Despite all this, despite our protocols, let me say this, that the quality paradigms require policing. Quality paradigms require policing, and I'm going to illustrate this by a small story. You know, in Japan, they eat a lot of fish. And because they eat a lot of fish, the Japanese, they go and they send out their tankers and they get the fish. But what has happened is that in the immediate coastline, they run out of the quantum and the quality. So they go deeper. So if they go deeper, by the time they get back, the fish is of poor quality. So they decided, let's try and improve the quality of fish. So what did they do? They got big tankers. And they got big tankers and they stuffed all the fish, all the catch from the deeper areas and got them back. But by the time they got back to shore, the quality of fish was not as good as it should have been. It wasn't fresh. So the Japanese are very sticky about what sort of fish that they want to eat. And therefore, they innovated. So what did they do? They got bigger tankers. And they said, this time, you allow the fish, you fill them up, but you allow them to swim around. They don't die. It's not stuffed. They don't die. So they had water, so they could, and they had oxygen, and they were live tankers where they were swimming, but they were full. So the tankers were chock-a-block full. Because they were chock-a-block, so the fish was idle and slow and sluggish and was not moving. So the taste of the fish changed once again. So the Japanese were thinking, the Japanese were innovating. They wanted something better. So you know what they did? They put a small shark. They put a small shark into the chamber. And you know what happened? When you put a shark in the chamber, the fish were moving all over the place. And that changed the way the Japanese, even today, continue to do. So quality paradigms require policing, and I think the shark story says it all. So I'm not going to say more than what I already have, but let me say this, that it has been difficult to assume quality, to assure quality, as we have been discussing the whole morning. So therefore, if you can't really redefine quality, outcome parameters become a little difficult to. So we in the armed forces, despite having such incredible SOPs, we still find ourselves very often at a loss. And I think it's time that healthcare institutions need to find valid indicators of quality control which can connect the structure and the process to outcomes. I think that's something which is still elusive, and we still haven't. The challenge is even more because as there are evolving dynamics with more of medical technology coming in, to keep pace with the best practices today in medicine will continue to be a big challenge for us as healthcare professionals. Until then, I think healthcare managers at different levels will have to be the sharks, so to say, to monitor quality of healthcare at different echelons of care. Ladies and gentlemen, I thank you for your attention. Thank you, and Jai Hind.